All right. Good day. We can get started. And welcome to you, and thank you for your participation in this quarterly external compliance webinar. The topic that we're going to cover today is Mental Health Parity and Addiction Equity Act of 2008. And then we're going to also discuss quite a bit on the non-quantitative treatment limitations, comparative analysis that's also required to be performed by the plans. And so we'll talk to you about your obligations surrounding that. We'll do a brief summary on compliance updates, calendar items, and other legislative activity. And just to the last housekeeping is that the next quarterly meeting is in November, and due to the conflict with the Thanksgiving holiday, we will have that November 19th. So please mark your calendars for that. And we will be doing the topic that we will be covering will be the employer shared responsibility. All right, so today's training objectives. So first off, we're just going to talk about what Mental Health Parity and Addiction Equity Act required, impacted. We'll also talk about how parity applies with respect to three key areas: financial requirements, quantitative limits, and our favorite by the end of the hour will be the non-quantitative treatment limitations. We will also discuss why this comparative analysis is required for the non-quantitative analysis and what are the key deliverables in ensuring that your plan's successful should a regulator ask for the analysis. And then we will be talking about what are the required elements of a defensible analysis or report that does get issued. And then you do, as plan sponsors, have obligations with respect to disclosure requirements. We will talk about who you are required to disclose information to and the penalties should that not occur. And then we're also going to just kind of high level go through an action plan for fully insured versus self-insured clients. And then we're going to talk about a couple tools that are available to you that are actually quite good. All right, so moving on. So what is mental health parity? And first, so it is a law that started out being a federal law, but most states have adopted some form of a mental health parity regulation as well that will cover insured products. So the federal law actually covers employer sizes 50 and above, and there are some exemptions that we're going to be talking about. The one exemption is that self-funded plans, if they're, again, if they're under 50, they are not required to comply and can get an exemption. Retiree-only plans are another example. And then depending on your state, it will depend on what size for fully insured products. So you'll probably want to understand those laws because that's 50 great states. The key requirement behind the plan is it doesn't require the coverage of mental health and substance use disorder benefits. But what it does do is if those benefits are provided by a plan, then they must be on par with or richer than medical surgical benefits. So throughout today's presentation, I could be using mental health interchangeably with behavioral health. You may hear me say med surg, you'll see MS. So I call those categories. And then later we will be talking about classifications. So I just want to make sure that you're on the same page as I am. as we move forward. So again, mental health parity for those plans that do cover mental health and substance use disorder benefits, they can be no more restrictive than any predominant requirements or limitations. Now, here's just a list of some of the limitations. There's financial requirements, which most of those you all have adopted and have been in your benefit plans and are on par for many years. Treatment limitations, those also not quite as easy as financial requirements to spot, but they also are numeric in nature, and I'm going to give you a few examples of those. Network admissions, medical necessity, that's just a couple examples of the non-quantitative treatment limitations. So again, we talked about if a plan offers the benefits, it's not required under the law, they must be on par. Self-funded plans, who enforces is the Department of Labor. For fully insured plans, it's CMS and the various states. So you do need to be careful. Again, the states, what happens is under the ACA, there are state benchmark plans. The various states in filing their fully insured plans with their the Department of Insurance or other similar entity. They will identify the state benchmark plan. Many of those benchmark plans, which again just say no cost sharing limits on those, essential health benefits, they may actually cover and include mental health and substance use disorder. So on the fully insured side, you can't necessarily say, oh, I'm just not going to cover them, because there may be some state requirements that will make you automatically have to comply with mental health parity. So then with respect to non-quantitative treatment analysis, again, I would say between this and employer shared responsibility, this is probably one of the top three, or they're both in the top three most complex compliance requirements. So this is not an easy topic, but we'll hopefully unpack it so that you have a clear plan forward. So again, non-quantitative treatment analysis, that is non-numerical restrictions that are that the group health plan puts, and it's really about limiting actually the access, scope, or duration of medical benefits. And oftentimes it involves operational or clinical rules, which are not necessarily transparent to you, for example, in a fully insured program, and may not be in a self-funded program as well. And we'll talk about that. So the analysis includes not only the design and whether the design itself makes sense, but does the application of that design end up with outcomes that are on par. That's what the report is also doing, is analyzing to make sure that the application is intended as expected. So I've got a list of examples here. I will be presenting them, and we'll kind of give you a couple more examples in a future slide. Now, high level, the report itself must be available upon request. And there are various departments that can request it. The trifecta, as I call the DOL, HHS, and Treasury, in addition to state agencies that will govern. So in some states, it might be the insurance department, and others, it might be the Department of Health. So there are various agencies that can request this report. And then later, we'll also talk about other individuals that may request the report as well. And again, high level, the non-quantitative treatment limitations must not be more restrictive, again, for mental health substance use disorder versus med-surg. So moving on, again, we've touched on some of these, but generally this does apply to employers that are 50 plus. for self-insured. And then again, for insured, it will depend on the small group status and those state benchmark plans of the various states as to whether or not your plan has to comply. If a plan offers again the mental health substance use disorder, then they must be on par. It is going to, that parity must apply to the three different areas that I've discussed, and we'll have a slide that will present them. And then again, it generally must provide the same access to care and patient cost sharing structure for compared mental health substance use disorder compared to med-surg. And then one note is plans may not separate deductibles for these two categories, as I call them. And so a single combined deductible will meet the requirement. So moving on, again, affected arrangements, we've talked about them. I will also mention that pharmaceutical benefits also apply, and usually that is done separate from the medical plan, and that analysis is done separately in concert with the PBM. And the other thing is, each medical plan has to have its own analysis. So, for example, I've worked with a very large hospital client that had 6 different plans, and all 6 of them required the analysis. Now, there was some synergy amongst all of them that could be used for all of them, and then the data was just supplied differently. But you do have to produce a report for each of the plans, including separately the pharmacy. And then grandfathered plans is also another exemption. So if you're a grandfathered plan, you all are not subject to these requirements, or you have an exemption from the requirements. So why the analysis? So the plans and issuers themselves, they will typically perform this analysis themselves, and they'll be using it on their overall population as the overall benchmark. But recognize that just because they do it, it may not be comparable to your plan itself, which may, for example, you might be a California plan that happens to have a subsidiary in Dallas. And so that the majority of your employees are concentrated in those 2 areas. You may then want to ask questions of your carrier about how it could differ, based on your geographic regions. And I'll give you some more tips and tricks about that later. The analysis, as I said, must be available upon request of the departments, state authorities, and then also individuals, which we'll talk about with disclosure requirements. I have participated in webinars where the individual or the agencies that actually review these reports have done webinars. And you go away not very happy because they pretty much tell you that there has been no comparative analysis that's really been done 100% correctly. So we're all in the same boat, but I will tell you by the end of this meeting, maybe we will get closer to that being the star. Self-insured sponsors are often surprised that the plan or the vendors are not completely responsible, and they're not. But even in a fully insured case, the plan does have some obligations as plan fiduciary. So, what is considered insufficient? So if you hear from, say, one of the BUCAs that, oh, we're in compliance with mental health parity. Again, that's not good enough. A broad conclusory reference to some high-level processes and standards. Say you go to your network or you go to your utilization management companies and they say, oh yeah, our processes are in compliance. That is not necessarily good enough. Missing explanations on on explaining the data, the disparities, the discrepancies, and then no plan-specific documentation that is specific to your plan is not available. So those are kind of common insufficiencies. We'll be talking about the annual report to Congress, and so how you can look at that year over year to see what seems to be of importance. I will tell you whether it's this administration or the prior administration or the next administration, they are all very supportive of mental health parity and want it and do plan to have compliance enforcement. Now, we're going to be talking about they did finalize a 2024 rule, and parts of that, and basically there's a non-enforcement to that, and we'll be explaining that later. But what really, if a department does review and analyze it, what can they do to the plan itself to help enforce the compliance? Well, the best would be just a corrective action plan and that they're working with you to move towards compliance. The unfortunate part is sometimes it's a very short turnaround time for implementation. And depending on how many vendors are supporting your program, this may not be an easy or quick task. Sometimes there's required removal of problematic non-quantitative limitations. The worst case scenario that I've had a regulator explain is where a claim was denied and was not on par with med-surg in the behavioral health and substance use disorder. They required the plan to go back and retroactively adjudicate claims back several years for that particular denial. So that's worst case scenario. That isn't necessarily that frequent, but that I'm just trying to give you the sort of the bookend range of enforcement. And then we'll talk about the participant disclosure requirements and penalties. And that is $100 or $110 per affected individual per day. And various people can request that. So what counts as a non-quantitative limitation? So in essence, they're the non-numeric limits that impact access, scope, or duration of benefits. And again, from a parity perspective. Examples that are pretty easy to understand. The most common is your prior authorization. So really you need to look at your prior authorization, your trigger lists. You probably look at those and review those with your relation producer and service team on an annual basis, and making sure that you don't have anything on your trigger list that was not intended. Many years ago, I was working with a plan that wanted case management to get involved with transgender affirming care right away to make sure that individuals that do obtain transgender affirming care get the best and are connected and are case managed. So they meant well. But the problem was they added it to the list when it was not on par with other things. So then in the future, the plans, and we always looked for this, is we made sure that yes, a surgery could be on the prior auth list because you often do that on the because on the surgical side, you do have that. But when it comes to the medical care for transgender affirming care, that should not be on your trigger list. So that's an example. Utilization review and concurrent review, we're going to talk about. A lot of that depends on the personnel themselves and the sources of information that they use to evaluate their criteria for MedNess or experimental investigational. And then even pharmacy, like one that they particularly look at is step therapy. Again, step therapy is where let's try to make sure that the lowest cost medicine works effectively. And if not, then we'll go up. Again, making sure that if you have that in there for a mental health, substance use disorder prescription or related prescription, that you're doing similar on the med surgical side. And then provider network, their admission, their reimbursement rates, their composition, all of those are also fair game. Their credentialing operations, and I'll give you a couple more examples of that later on. And then out of network reimbursement methodology. So this is where you can look at your plans today and look at, okay, how do they calculate or what rate do they reimburse for out of network? Number one, I'm always a proponent of not conditioning out of network reimbursement on a condition. So, historically, many years ago, people would, for example, have a dialysis benefit based on Medicare or a certain price. It is better to not condition benefit or reimbursement on a type of condition. That's just a better practice. But for example, some plans use just a Medicare reference pricing. Sometimes Medicare pricing is not a good reference because Medicare is for a traditionally older population. The commercial population tends to have more children, babies, teenagers. They likely have more of a incidence of maybe substance use and potentially. And so it's really important to come up with a strategy for reimbursement that will work across these categories. Compliance tips, just know that Parity is not just about the copays and visit limits, even though those are easy for you to review your plan documents and policy documentation. The key to non-quantitative treatment limitations are really the vendors, the vendor processes, and the operational rules for all of them. So whether that's a carrier, a TPA, a PBM, a UM vendor, case management vendor, any of those vendors that make key decisions with respect to med surge versus mental health and substance use disorder are fair game. So it means that you need to ask great questions of them as to what their underlying operational and clinical, in some cases, processes are. So with respect to the analysis, it is also very important that in addition to separating by the categories, which are the med surge and the mental health and substance use disorder, there are also 6 classifications that your analysis needs to cross. And that is and as they're listed here. In the case of outpatient, you could actually also further delineate those classifications into office visits versus other outpatient items and services. I know many actuaries will pull the data that way and separate it out so that you can analyze it that way. If you're working with a carrier or TPA, oftentimes they have healthcare analytics teams that are able and have scripts ready to pull this kind of data in these classifications once you have engaged a vendor to perform this analysis on your behalf. So again, the analysis will actually address all 3 of these areas, even though the more complex area is the non-quantitative treatment limitations. So financial, those are easy to spot. And again, the idea is that they're not any more restrictive in comparison. You can always have richer benefits for mental health and substance use disorders. And I see that frequently done, where they actually have better richer benefits in order to ensure that those individuals get access to those treatments. Quantitative treatment limitations, again, they're numeric in nature. They can be number of days, they can be number of visits, treatment, etc. I will give you one example. I worked with a plan where there was one individual that had substance use disorder, and they actually admitted that they went to out-of-network residential treatment centers in order to obtain room and board. They actually admitted that to the case manager. So we stepped back and we looked at the data, and the individual had actually gone to the treatment center 26 times. Now, there was some brokering that got involved, which is a totally different story, but that caused that number to be very high. But so they wanted to limit it. Well, we reminded them that under parity, you have to make sure that if you're, depending on how you're going to classify your residential treatment center, are you going to treat it like skilled nursing? Are you going to treat it as inpatient? How are you doing that? How is your plan defining that? Once you do that, you need to make sure that if you put a limit on the number on that side, that you have to then also limit the number maybe of inpatient visits for medical reasons. So there are some strategies you can deploy that are still compliant, but you do need to look at the overall picture on some of these benefits, and not just try to, look at that one scenario on the out-of-network side. The actuaries or the vendors that do perform this analysis, when they look at quantitative treatment analysis, they'll use, there's a couple of different actuarial tests that are known in the industry. One is substantially all, the other one is a predominant test. Either way, they'll apply one of the tests to the non-quantitative treatment limitations, and again, opine as to whether or not you're on par or not. Now, non-quantitative treatment limitations, we have touched on various examples. Again, one of the areas, say, for example, medical necessity criteria. So some of this, and we're going to be talking about factors and sources, but under medical necessity, most insurers or TPAs are working with their community, the other payers and providers in a non-antitrust way, and they're developing what's the community standard for medical necessity criteria that's being used in a given region sometimes. Sometimes it applies across the nation, no matter what. So it does, there are guidelines, for example, on the medical side that are used. A national source, for example, is Hayes. In the case of transgender affirming care, they don't have guidelines with respect to transgender affirming care. So the other nationally recognized tool is WPATH criteria. So again, it's really about, yes, you can have disparities and discrepancies, like Hayes doesn't apply it to everyone, but as long as that's documented and those decisions are again being applied on in a non-disparate way. And then reimbursement methodologies, I use the example of a California plan that has a high concentration of Dallas. Again, when it comes to reimbursement methodologies, you may ask your networks to actually do an analysis of the where there are certain procedure codes and provide zip codes that are in California and Dallas, as opposed to using national benchmarks to determine whether or not the reimbursement methodology is on par. Now, recent updates. So I mentioned previously that on an annual basis, there is a report that is part of Mental Health Parity and Addiction Equity Act. It's a requirement that Congress has a report for the period August 1st to July 31st each year. So they will publish it and report it to Congress. And so that's where you get what are some of the key deficiencies that they're seeing and what seems to be the issues. And that's how Congress continues, or maybe the guidelines, proposed rules get modified based on that congressional report. And then that will kind of help determine where they're going to look next at the agencies. In addition, in 2024, the trifecta did finalize a rule. I was in various industry meetings on that specific rule. It was very highly complex, and participating in the meetings were actuaries from the largest BUCA plans. And those actuaries said this is very difficult, and in some cases, these provisions are very difficult to implement or even calculate. So they did adjust their sales a bit, but they did publish a final rule in 2024. Well, the ERIC committee, or the ERISA Industry Committee, filed a lawsuit against the agencies, and it is currently pending litigation. So, because of that litigation, Trifecta came out and said, look, we're not going to enforce these provisions. So, basically, you should all take them as best practices, try to start implementing them. They said that it will not be enforced until the litigation is decided and then 18 months out, so that the agencies can modify or adjust their sales and put out adjusted guidance. There were some provisions that already got implemented in 2025. The carriers and TPAs have already adopted them. There was another set that went into effect in 2026. I'm confident that they're all implementing the ones that made sense and that they could move forward on. And again, this non-enforcement does not count towards, oh, good, I don't have to do a report. They have made that perfectly clear. And they've also emphasized the fact that the plan sponsors themselves have fiduciary responsibility. So for some of you that have larger plans, you have a fiduciary committee, you may want to just put this on as an annual event that you obtain the documentation, whether it's from the fully insured carriers and PB, and then get it from your PBMs, or if you engage a vendor or the TPA and a preferred vendor of theirs, an actuary, to perform this analysis, and then actually put in minutes that you actually review it, and that any notations on deficiencies that you're working with your relation producer and service team to shore up any of those gaps. So roles and responsibilities, I did just speak to the fact that the employer, of course, is the plan fiduciary and has overall responsibility. The producer and service team, last week I had an internal compliance where we even went deeper, and I gave them strategies on how they can work with all of you on how to ensure your compliance. Of course, fully insured plans, again, you can obtain the documentation. Last week, after I provided the internal compliance webinar on this, I actually had one of the teams that had just had an audit conducted by us, and they reached out. They happened to have United Healthcare, and so they reached out to United, and there were like 15 different documents that represented the different non-quantitative treatment limitations that they provided. So I will, so that will go into the audit binder for them for the year so that they can demonstrate they have it. But then then there should also be a high level review to see if there were any exceptions and then document that they have been reviewed and any action items or steps you might want to take as a result of it. And then again, really working with the identified partners and really understanding their methodology, their mapping, and then any conclusions. And by looking at the congressional report, are there key risks that we need to be that the plan needs to be focused on? So high level action steps, you probably, I'm now just writing the plan for you, is really identifying those vendor partners. And this is just some of them. There's various, your claims adjudicator, your healthcare analytics team that can pull data, the utilization management team, case management, your PBMs, what are all of the networks you use? Maybe you use domestic, friends and family, wrap networks, national wrap networks. All of those really need to be identified so that you can be getting assurances and documentation from each of them that is on point. Then, of course, it goes without saying that you would identify your financial and your other treatment limitations that are numeric in nature, but you're going to naturally do that as part of your benefit design. It's the NQTLs that are much more difficult to get your arms around. You could also, in some cases, if you're looking at evaluating a vendor, for example, you could ask them specific questions about non-quantitative treatment limitations. Again, some examples are with respect to medical management, it's really looking at what is the background of maybe the chief medical officer. Is there also a comparable one on on mental health and substance use? Is there a different level of clinical representative that has different expertise? Documenting that with respect to networks, again, it's your network adequacy, it's their credentialing policies. Do they have a denial rate that's higher for mental health and substance use disorder providers than they do for med surg? The good networks already will be looking at that information in their committee meetings on an annual basis and be documenting that information for you. And then the factors itself, that go into the design of the non-quantitative limitation, and then the sources. I use the example of Hayes. There could be various examples of good sources of data, and I have another slide on that as well. Then pulling the data, again, based on and slicing and dicing it by category and classification, the 6 classifications, and if you want to, the further slicing of outpatient between, you can do that as well. And so that's important. And then really that written documentation of demonstrating that you've looked at it, the comparison, if there are gaps, do you have any action plans you can take to try to improve it? There are times that you just can't. From a data standpoint, for example, it's sometimes just a law of small numbers. In that example where I worked with a client that had 6 plans and they did the data pull and sliced it down. They actually, on the claim side, had only 2 claims that went out of network. One of them was mental health, substance use disorder claim related. And so it became a 1/2 or a 50%, where the denominator created the issue. It was hard to say that the network itself wasn't adequate when you only had 2 claims that went out of network for outpatient, as an example. So there are times you just might have to document that you looked at it and there just doesn't seem to be anything further you can do. Maybe you have all of all of the key providers in the network somehow just trying to dispel where there are those gaps. And sometimes you just can't, there isn't always a rational or something that you can do to really impact that number going forward. But it's not only claims data, it could be appeals data, both denials and overturned denials. It could be, medical necessity and experimental investigation approvals and denials. Again, all of those areas from a data standpoint should be sliced by category and the six classifications. I'm not going to go through these. The slides will be available to all of you after this webinar, along with the recording. These are examples of the sample NQTLs, most of which we've already discussed and given examples. And then the factors and standards, usually the actuary or the vendor will help get the right questions that you can ask each of the vendors that you have that is supporting your plan. But these are some of the examples of factors versus standards that you can see. So just to give you some ideas, this is not an exhaustive list, but it certainly you can ask your vendor some of the questions if you believe that any of these factors or standards would apply to them. We've talked high level about common findings that you need clear descriptions. You do need to identify those factors, evidentiary standards, processes. And again, this isn't falling on you. It's really about asking the right questions, working with the right vendor and actuary partner to be able to get the right questions asked of your vendors who will be able to help you. The required elements of the report or the analysis itself are if you can, once you get the report from the vendor that has created it, is kind of use this as a checklist as to whether or not the report contemplates these various items. Most of them are pretty standard now and automatically will have the various sections. Now, disclosure requirements. We've talked about turning it around if any of the agencies, the federal agencies or state agencies, request this of you. But there are further obligations as an ERISA plan to be able to explain the decisions that are made and provide documentation to support it within so many days, depending on what it is. So, for example, if you have a denial on Med-Ness, the requirement is within 30 days of that denial. If the participant, a beneficiary, a provider, has asked for information on how to do this, that gets supplied within 30 days of denial. Many TPAs and carriers actually post medical necessity criteria and policies on their external websites many of them have pages on providers that will actually post that guidance, and they'll tell you whether or not, what is the source of if there's a clinical policy on Med-Ness, they'll have footnotes whether they used Hayes guidelines or some other guidelines. So that's important. The internal claims and appeals processes, most of them have automatically adopted good, sound ERISA practices. So they're automatically going to provide to the member or the provider that's asking the supporting documentation that supports that decision, whether, again, that's medical necessity, whether it's an appeals decision, or whether it's just processing a claim. And then again, the fines and penalties can be $110 per individual per day. And there is a model request form that you can provide to an employee if they come to you and say, hey, I want to know some more information. You may actually ask them to fill out a standard model questionnaire to kind of limit and so that they can explain exactly what they're looking for. Many vendors that have that are doing and appeals processes already build that in as part of their process to provide applicable plan documentation provisions as well as any policies or procedures that went into supporting that decision. So, client takeaways, really just maintaining that current inventory of who are your vendors, who are your plans, and the inventory of those NQTLs ultimately. Again, who's going to be performing the analysis? How will you get that? And are they going deep enough to so that it's more than just plan design and it includes operational and clinical decision-making support? Obtaining evidence or data from any of those vendors that are listed here. And don't forget if you have any programs that are carve out, they may also be implicated if they're offering benefits to both med surg and mental health substance use disorder. Prioritize reviewing the ones that I've listed here because those are the highest risk and the ones that they're automatically going to ask you about. And then again, treat that 2024 final rule not as you don't have to do the analysis, but that it's best practice. So move towards adopting as much of it as you can until that final decision is made by the courts and then the 18 months later effective date. Now, this is the DOL self-compliance checklist. I won't read it to you. It's here. There is also really good for those of you that have access to XyWaves, and if you don't, reach out to your friendly relation producers and service teams, and they'll help get you that access. There is a great XyWaves document in general on self-compliance for mental health parity and specifically the non-quantitative limitations analysis. In there, they also do have links to the DOL, but you can also just Google DOL and you can also get to the self-compliance checklist that they published years ago and they update it frequently. And it's about 36 pages, but many of what I've discussed here today is included in that report. So that will help you just kind of reinforce things that we've discussed today. All right. Well, thank you for that patience. I really appreciate your patience as we walked through a very complex uh, compliance requirement, and that has a lot of variability. If you have any questions about your specific plans and what you're doing, feel free to reach out to your relation producer and service teams. If they can't answer those questions, they reach out to us daily, and we're happy to answer those questions or at least point you in the direction of what makes sense. We, as a relation, also has preferred vendors that have preferred arrangements to do the analysis itself. So again, you can reach out to your teams to identify. Again, for the most part, if you can use somebody that's recommended by your issuer, carrier, PBM, and TPA, and one of their preferred vendors to do the analysis or the actuarial review, that's always helpful. Again, if they're the same party that does data analysis for your plans, that's also helpful. But it doesn't have to be that way, but that can get you close to having a comprehensive analysis. So upcoming compliance calendar deadlines. This is both self-funded and fully insured. Just as a reminder for the fully insured plans as of September 30th, if your plans did not meet the medical loss ratio levels, for small group that's 80%, for large group that's 85%, they will return a rebate to the employer. And if they do that by September 30th, they usually use data that's run out through July 31st, then they will and it's performed on a calendar year basis, you then, as an employer and plan, will have 90 days to deploy a strategy to spread that rebate across the plan so that the existing plan benefit members can benefit from that rebate as much as possible. And there's different strategies. So legislative updates. So we did talk about that there's another phase of mental health parity that's going into play. PBM fee disclosure. So there were some rules that immediately went into effect, but there will also be some other PBM disclosure requirements and frequency of reporting depending on size that will be coming out. So we're watching that. The other thing I might mention is the IDR process. So there is a recognition. Relation participates as a member of the Council of Insurance Agents and Brokers, and they work with lobbyists to try to shape the regulations impacting employer benefit plans. And there is a recognition by Congress that even though has been a final rule with respect to the IDR process, which you'll see at the bottom of the slide here, what are the final rule provisions? While there's some nice wins like lower administrative fees from 115 to 15 per party, it is still increasing the number of wins for those out-of-network providers that never will negotiate in the first place. So it's those out-of-network providers that aren't negotiating upfront anyway. So this is still coming under advisement. We have been asked, and Relation does try to provide some guidance based on what we know, and to try to ensure that the IDR process really does work as intended and does not just increase costs for plans. And then the other thing I would say is that for the last year, we've had continuous guidance on the Trump accounts. The most recent guidance on the Trump accounts does highlight that non-discrimination testing applies. So you really have to look at how the plan itself is creating a program. So if a program for Trump accounts that the employer is sponsoring just basically allows the employee themselves to take pre-tax deductions to include in their dependent child's Trump accounts, then that will be subject to the Section 125 because it's really about cafeteria pre-tax elections. And so the tests that you would apply to Section 125 and the definition you would use for highly compensated individuals will come out of Section 125 rules. The Trump accounts itself is Section 127. So if it is that the dollars that the employer is going to provide will be given directly to the employee to add to the and offered through Trump accounts, then it's Section 127 IRS non-discrimination testing requirements. And they've said they're going to mirror what plans do for dependent care assistance programs. So the Section 127 Trump accounts will be on par, both the definition of highly compensated individuals and the actual tests required will be similar to the dependent care assistance programs. All right, thank you. We are at the top of the hour. Becky, do you know if there were any questions?
No, we don't have any questions at this time.
Okay. Well, thanks everybody for your participation. Feel free to send along questions or send them through your relation teams. And I hope everybody has a safe and happy holidays throughout the remainder of this summer. Take care and have a great rest of your day.